Hello everyone, this is Dr. Govind Raikar. In this video, we will discuss about pancreatic hormones. We all know endocrine pancreas, or we can say islet of Langerhans. It contains several cells, the important being alpha, beta and delta cells. Alpha cell secrete, yes, it secrete glucagon. Beta cell secrete insulin and delta cell secrete somatostatin. Once the question was asked, which are very easy, which hormone is secreted by beta cells of pancreas? But the options were not easy. There was no insulin in the option. So which other hormone is secreted by beta cells of pancreas? Yes, it is amylin. Now what is the function of glucagon? It is to increase blood sugar. Function of insulin and amylin is to decrease blood sugar. Whereas somatostatin is function is to decrease both insulin and glucagon. And somatostatin we have already covered in pituitary. So here we will mainly discuss insulin and glucagon, starting from glucagon. We just discussed the function of glucagon is to increase blood sugar. So for which purpose we will use it? Obviously for treatment of hypoglycemia. So glucagon, it can be used to treat hypoglycemia. But the question is, for which hypoglycemia it is not effective? Which type of hypoglycemia cannot be treated by glucagon? Now to answer this question, we need to know how glucagon increase blood sugar, how it reverse hypoglycemia. It increase blood sugar mainly by causing glycogenolysis. It breaks glycogen to form glucose. So if glycogen is not there, how it will be effective? So glucagon is ineffective in case of starvation induced hypoglycemia. In starvation induced hypoglycemia, glucagon is not effective. Because if a person is starving, person has not taken food for 2 days, 3 days, 5 days, obviously the glycogen must have been consumed by then. So how will glucagon work? So glucagon is ineffective. The treatment will be to give food, to give glucose. Okay. Second, it is also not effective in alcohol induced hypoglycemia because alcohol interfere with glycogenolysis. So it will be ineffective. So glucagon is effective in hypoglycemia but not in starvation induced or alcohol induced hypoglycemia. Clear? Now what is the non-hypoglycemic use of glucagon? Apart from hypoglycemia, where else we use it? Yes, glucagon is a drug of choice in beta blocker poisoning. The question is how it will work. First we'll try to understand. This is heart. It contains beta 1 receptors. We all know beta 1 stimulate the heart, but question is how beta 1 stimulate the heart. So when the ligands like adrenaline, noradrenaline, they stimulate beta 1 receptors. Beta 1 is a G protein coupled receptor. So through the G protein, it stimulate cyclic AMP production. So more cyclic AMP is produced. And it is this cyclic AMP which will stimulate the heart. So cyclic AMP is required for stimulation of heart. So in case of beta blocker poisoning, beta receptors are not activated. So cyclic AMP is not produced. So the heart is depressed. So this person has bradycardia. This person has decreased cardiac output. So heart is depressed. So now we need to stimulate the heart. In beta blocker poisoning, our aim is to stimulate the heart. But we cannot stimulate the heart by stimulating beta 1 because it is already blocked. So drugs which stimulate beta 1 like adrenaline, noradrenaline, dopamine, dobutamine, they are not likely to be that much effective because the receptor is already blocked. But we have to stimulate the heart. So how we will do? So we want to increase cyclic AMP by some other method. And what method we utilize is, we know that glucagon receptors are also present on heart. Normally they are present. So when we give glucagon from outside, it will stimulate these receptors. And these are also G protein coupled receptors linked to cyclic AMP adenylate cyclase. So these will increase cyclic AMP. So when cyclic AMP increases, the heart will be stimulated. The question is, are glucagon receptors normally present on heart? We said yes. If they are normally present on heart, why glucagon normally do not stimulate the heart? The reason is, normally beta 1 is also working. And suppose when we stimulate beta 1, it produces 1000 cyclic AMP. On the other hand, when we stimulate glucagon receptors, it produces 100 cyclic AMP. So in presence of those 1000 cyclic AMP, these 100, there is no importance. But when those 1000 are not present, as in case of beta blocker poisoning, these 100 become life-saving. Okay? So that's why glucagon is a drug of choice in beta blocker poison. Drugs acting through beta 1 are less likely to be effective. Okay. Now, what are the other methods to treat beta blocker poison? Basically, we want to stimulate the heart without beta receptors. So what else method you can use to stimulate the heart? Yes, we can give anticholinergic drugs like atropine. Atropine will block the M2 receptors that will stimulate the heart, reverse the bradycardia. We can directly give calcium. Calcium will directly stimulate the heart. Or we can give phosphodiesterase inhibitors. They will inhibit the metabolism of cyclic AMP that will stimulate the heart. Okay. So these are the different drugs can be used in beta blocker poisoning. But remember, glucagon is a drug of choice. Okay. So that is important about the first receptor, this hormone in the pancreas, which is glucagon. So glucagon used for hypoglycemia and for beta blocker poison. Okay. So now we will move to our main hormone, which is insulin. We all know function of insulin is to decrease blood sugar. So where we will use this? Yes, of course, in case of diabetes mellitus. Which type of diabetes? Yes, it is type 1 diabetes mellitus, or we can say insulin dependent diabetes mellitus. So as the name tells, insulin dependent diabetes mellitus means this type of diabetes mellitus is dependent on insulin. There is absolute insulin deficiency. So this type of diabetes mellitus cannot be treated without insulin. So all patients of type 1 diabetes, they require insulin. All patients of type 1 diabetes require insulin therapy. Then there is another type of diabetes called as type 2 diabetes mellitus. The other name is non-insulin dependent diabetes mellitus. As the name tells, this type of diabetes mellitus is not dependent on insulin. That means it can be treated without insulin also. And when we can treat without insulin, we will try to treat without insulin only. Why? Why we will not like to give insulin first? Because the name of insulin is ending with in. And any physiological substance whose name ends with in is a peptide. Like insulin, oxytocin, vasopressin, angiotensin, bradykinin, any substance ending with in is a peptide, physiological. And what is the problem with being a peptide? Peptides cannot be given orally. There are already enzymes waiting in the GIT. Pepsin, trypsin, chymotrypsin, they are already waiting. So whenever we give any peptide orally, it will be broken. So it will not be effective. So is insulin. So insulin is not effective orally. It need to be given by injection. And how long you need to treat diabetic patient? For type 2 diabetes, type 1 diabetes, how long will you need to give insulin? Yes, it is lifelong. And who will prefer injection lifelong? So first of all, we will prefer oral drugs. So in type 2 diabetes, we will prefer oral drugs first. But if oral drugs are not able to control blood sugar, then we can use insulin. So that means for uncontrolled patients of type 2 diabetes. Remember, the name says non-insulin dependent diabetes mellitus. It is not dependent on insulin. It can be treated without insulin also. But we never said that insulin cannot treat. Insulin can treat this also. Okay? So uncontrolled patients, we will like to give insulin. Okay. Then we have diabetic ketoacidosis. Insulin is drug of choice. It is an emergency situation. We have to give insulin. Diabetic ketoacidosis. Then diabetes in pregnancy. insulin is drug of choice for gestational diabetes or any diabetes in pregnancy. It do not cross the placenta, so no risk of fetal hypoglycemia, which is present with most other drugs. Okay? Now, any other use of insulin apart from diabetes, apart from hyperglycemia? Yes, very important use. It is hyperkalemia. Very important to remember. Potassium, which is present in the blood, potassium, it is afraid of two things. One, insulin, and second, salbutamol. So whenever insulin or salbutamol come into the blood, because of fear, this potassium will immediately leave the blood and go into the cells. So basically salbutamol and insulin, they help in intracellular movement of the potassium. So from the blood, the potassium will go into the cells. So if there is hyperkalemia, that will be corrected. Okay? So insulin and salbutamol, they are used in acute hyperkalemia. But because of same reason, they can cause hypokalemia as a side effect also. Okay. So these are the important uses of insulin. Now coming to the routes by which we can give insulin. What are the different routes by which insulin can be used? The most common route of insulin administration is subcutaneous. Now why we prefer subcutaneous over other routes? Because this is the injectable route which can be self-administered. अपने आप ले सकते हैं. Self-administration is possible, and if we are planning to give a drug for long periods, we want that person should be self-sufficient. Okay? Intramuscular, we need to give very deep. It is usually not possible by self. IV is very difficult to practice. So subcutaneous is the route which can be taken by self. So that's why it is most commonly used. Almost all preparation of insulin can be given subcutaneously. Now second thing is, on which place, on which area of the body you will give subcutaneous insulin. The most common site of insulin administration subcutaneously is abdomen. Most common site is abdomen. We can give on the abdomen. Almost any place in the abdomen we can give except around umbilicus. The thickness of skin around the umbilicus is not uniform. So we are not sure how much insulin will be absorbed or not absorbed, because we want tight regulation of glucose. So insulin high or low can cause problem. So we do not use area around the umbilicus. Any other part of the abdomen we can use. Then we can use on anterior thigh, lateral thigh, or even on the arm we can use. So there are plenty of sites where we can use, and usually these sites should be rotated. To prevent the risk of lipoatrophy, we rotate these sites. Okay. Then apart from subcutaneous, we can use insulin intravenously also. And the most commonly used insulin by IV route is regular insulin. Regular insulin. It is insulin of choice for diabetic ketoacidosis, because in this condition we want to give IV. Okay? So regular insulin will be insulin of choice. Then there is another route called as inhalational route. Insulin can be given by inhalational route. There was one insulin formed earlier called as Exubera, which can be given by inhalational route. But because of pulmonary complications, this insulin has been withdrawn from the market. Now another brand has come which is called as Afrezza. Afrezza has also been approved by inhalational route. But important points to remember, it is not a stand-alone insulin. That means we cannot treat diabetes by giving only inhalational insulin. We need to give injectable insulin. Injectable insulin must be given, and this is given just before the meals as a short-acting insulin. So long-acting insulins are given regularly by injection, and short-acting mealtime, just before mealtimes, we can give the Afrezza also. Okay. So these are the different routes of administration by subcutaneous route. Okay. Then coming to insulin preparations. What are the different types of insulins? Classically, we divide the insulins into short acting, intermediate acting, and long acting. Short acting insulin, it include regular insulin, Intermediate acting include NPH, neutral protamine hectron insulin. And then we have developed a combination of insulin with zinc. Insulin zinc combination is called as lente, and we have three type of lente. One is called as semi lente, second is lente, and third is ultra lente. So basically the concept is, when we add zinc to the insulin, zinc, it stabilizes the hexameric form of insulin. Remember, insulin normally exists as 6 molecules together, hexamers, and these hexamers are inactive. They must be broken down to form monomers, then the action will come. So if we stabilize the hexameric form and monomers are slowly released, the insulin will become long acting. So zinc do that function. So if we add more zinc, it will be longer acting. If we add less zinc, it will be shorter acting. Okay, so semi lente has less zinc, shorter acting. Lente has in between, so intermediate acting, and ultra lente more zinc, longer acting. Yeah? From the name you can remember, lente contains L in the name. L means long acting. So ultra lente means very long acting, lente means intermediate, and semi lente means less long acting. That means short acting. So these are the classical forms of insulin. All the insulins can be given subcutaneously. Only regular insulin can be given IV also. Obviously, it can also be given subcutaneous, but regular can be given IV also. That's why regular insulin is insulin of choice in diabetic ketoacidosis. Okay. After this, we developed newer insulins, which are actually called as insulin analogs. The insulins we have discussed so far, they are exactly similar to normal insulin. That means consist of 51 amino acid, 2 chains, everything is same. But in the insulin analogs, the name tells they have functionally similar to insulin analog. Same function, that means to decrease blood sugar. But their structure may not be same. So what we have done a little modification in the structure. Maybe changed one amino acid position, maybe deleted one, maybe added one. So change the insulin slightly so that function do not change, but that will change the pharmacokinetics. So we have formed analogs which may be very fast acting, ultra rapid or ultra short acting insulin. So we say rapid acting insulins or ultra short acting insulins, you can say. And we have ultra long acting insulins also. Ultra short acting, ultra long acting. The ultra short acting or rapid acting insulins include insulin Lispro, insulin Aspart, and insulin Glulicine. Whereas ultra long acting insulins include insulin Glargine, insulin Datamir, and insulin D-Gludac. So first of all, from the name you can find like insulin Lispro. So in this insulin, we have changed the position of lysine and proline. That changed the pharmacokinetics. So these all are insulin analogs which have this type of slight changes. Okay? From the name you can remember insulin Lispro, insulin Aspart, insulin Glulicine. All of them contain S in the name. S means short acting. So these are ultra short acting, or we can say ultra rapid acting insulins, very fast acting. But remember, all are given subcutaneous. So by subcutaneous route, they are fastest acting. Okay. Then ultra long acting, one drug you can remember from the name itself, large insulin Glargine, large acting insulin, large acting insulin. But insulin D-Gludac, which is the latest one, it is the longest acting insulin. Longest acting is insulin D-Gludac. Now these long acting insulins, they are very long acting insulin. They are also known as peakless insulins. Peakless insulin means they never attain a peak in the plasma. We have given them subcutaneously, and from that place they are slowly released into the blood, and they never attain a peak in the plasma. So when there is less risk of peak in the plasma, they do not suddenly come in the blood. So which side effect is unlikely? Yes, it is hypoglycemia. All insulins can cause hypoglycemia, but the risk of hypoglycemia is negligible or very less with the peakless insulins or long acting insulins. Okay. insulin glargine, it is available at pH of 4, acidic pH. Most insulins are available at neutral pH, so we can mix any two insulins, but with glargine we should not mix any other insulin because both will become ineffective. Okay, so these are the various types of insulins. Now coming to adverse effects or side effects of insulin. What is the most common side effect of insulin? Yes, it is hypoglycemia. What is the most dangerous side effect of insulin? It is still hypoglycemia. Hypoglycemia is dangerous. Person can die. Which side effect of insulin can be easily prevented? This is hypoglycemia, because we advise the person not to skip meals. Always keep sugar. So hypoglycemia can be easily prevented. So in nutshell, whenever they ask the side effect of insulin, it is almost always hypoglycemia. Okay. Second, we know potassium is afraid of insulin. So when we give insulin, potassium go inside these cells. So it can result in hypokalemia also. Hypokalemia. And third, if we keep on repeating insulin injection at same place again and again and again, that can lead to lipoatrophy. So these are the major adverse effects of insulin. Clear? So these are the important points regarding the insulin. Now we can discuss the drugs similar to insulin. That means the drugs which can be given orally. So we'll cover the oral anti-diabetic drugs. This topic in the books, in many books, it is written as oral hypoglycemic agents, but we like to avoid that term because from the name it looks like oral hypoglycemic agent, that we will give the drug orally and we want to produce hypoglycemia. Obviously not. We do not want to produce hypoglycemia. We want to normalize the blood sugar. We do not want to decrease it beyond normal. Clear? So the right word is oral anti-diabetic drugs. And the oral anti-diabetic drugs we can divide into two major parts. One, the drugs which act by releasing insulin, also called as insulin secretagogues. They secrete insulin. And second, the drugs acting by any other mechanism. Now why we are dividing like this? If a drug is acting by release of insulin, then it will require beta cells to function. Only then it will release insulin. So these drugs require minimum 30% functional beta cells. If beta cells are not available, they are not able to work, then this drug will be ineffective. On the other hand, there is no such criteria for other mechanism drugs. So the drugs which release insulin, they require minimum 30% functional beta cells. Second, if a drug is releasing insulin, it will cause same side effect which insulin causes. Yes, that is hypoglycemia. Remember, any drug which decreases blood sugar cannot cause hypoglycemia. Only those drugs cause hypoglycemia which decrease blood sugar by moving the glucose from the blood into cells, increasing the uptake of glucose by cells. So if the cells take up glucose from the blood, then hypoglycemia occurs. Clear? So insulin can cause hypoglycemia. So any drug which releases insulin is likely to cause hypoglycemia, whereas this side effect is unlikely with other drugs. So truly speaking, only this group can be called as oral hypoglycemic agent. These are not hypoglycemic at all. Okay. So before going to these drugs, first we will try to discuss how insulin is secreted. Then we can discuss how the drugs increase insulin. Okay. This is beta cell of pancreas. And we know beta cells, they store insulin. This is insulin. Insulin is stored. First of all, we need to know what is the function of insulin. It is to decrease blood sugar. So when insulin should be secreted? Whenever there is more blood sugar. So basically hyperglycemia is the most potent stimulus for insulin secretion. So whenever in the blood there is more sugar, whenever there is more sugar in the blood, glucose is present in the blood. So through the GLUT receptors on the beta cells, in the beta cells we have GLUT receptors. GLUT receptors are present. The glucose will enter the beta cell. So through the GLUT receptor, glucose enter the beta cells. And this glucose, it is metabolized to form ATP. Glucose is metabolized to form ATP. Now on the beta cells, there is a special type of potassium channels. This is a potassium channel present here. The function of potassium channel everywhere is to remove potassium from the cell. Remember, potassium is normally more inside the cells. So function of potassium channels is to remove potassium from the cells. Now this is a special type of potassium channels which are called as KATP, or simply ATP sensitive potassium channels. Means these potassium channels will stop working in the presence of ATP. So ATP will inhibit these potassium channels. So whenever glucose enter the beta cell, it produces ATP, and now this ATP will inhibit this potassium channel. So when potassium is not able to go out, so it stay inside. And potassium is which charge? Yes, it is positively charged. So positive charge will accumulate inside the cell. So when positive charge accumulate inside the cell, it will result in depolarization. Slight depolarization, it will open the calcium channels. Slight depolarization, it open the calcium channels, and now calcium will start entering. And when calcium enters, it cause complete depolarization, and that lead to release of insulin. Okay. So this is the mechanism of release of insulin. Quickly revising: sugar, glucose will enter inside the beta cells, produce ATP. ATP will inhibit the potassium channels. When potassium channel is inhibited, that will cause slight depolarization, and that open the calcium channels. Calcium enters, complete depolarization, and that will lead to release of insulin. Okay? So all the drugs which act by releasing insulin, they inhibit this potassium channel. Okay? So we will discuss these drugs first. Okay. So the first group of drugs which act by release of insulin, also called insulin secretagogues, all of these act by inhibiting the ATP sensitive potassium channels. And we have two type of drugs in this group. One is called as sulfonylureas, and second group is glenide group. The name of these will end with glenide. The examples of sulfonylureas, they may be divided into first generation or second generation sulfonylureas. First generation sulfonylurea examples are chlorpropamide and tolbutamide. Whereas second generation include glipizide, gliclazide and glibenclamide. On the other hand, the glenide group, the examples include nataglinide and ripaglinide. First of all, quickly revising the important point about all these drugs. All drugs are releasing insulin. They require minimum 30% functional beta cells. And second, all of them can cause hypoglycemia as a side effect. This question is very commonly asked in the exam: which anti-diabetic drug can cause hypoglycemia and which anti-diabetic drug cannot cause hypoglycemia? So we know all of them can cause hypoglycemia. So we need to find something common in the name, and that common thing is name end with "ide." So among anti-diabetic drugs, if any drug name end with "ide," it can cause hypoglycemia. Okay? So this is our mnemonic: drugs ending with "ide" will cause hypoglycemia. Okay. So apart from insulin, only those drugs will cause hypoglycemia where name end with "ide." Okay. So now we will discuss important points, particularly about chlorpropamide. Chlorpropamide, apart from these standard points which we have already covered, it requires 30% functional beta cells. It can cause hypoglycemia. It acts by release of insulin. Chlorpropamide, it can cause cholestatic jaundice. cholestatic jaundice is important side effect of chlorpropamide. Second, it causes release of ADH from the hypothalamus, posterior pituitary. And what is the function of ADH? To retain water or to retain sodium and water? Very good. It is to retain only water, not sodium. So when ADH is released, it will retain only water, that will dilute everything in the blood. So that can result in hyponatremia, also known as dilutional hyponatremia. Very important question asked, which anti-diabetic drug can cause dilutional hyponatremia? It is chlorpropamide. Now it is increasing ADH. So can you find out some condition where it can be used? Yes, where ADH is less, and that condition is diabetes insipidus. So chlorpropamide can be used for diabetes insipidus. So if the question is asked which drug can be used for both diabetes mellitus as well as diabetes insipidus, it is chlorpropamide. Diabetes mellitus we are studying, and it can be used for diabetes insipidus also. Okay. And third, it can cause disulfiram like reaction, intolerance to alcohol. So we have already studied in the central nervous system that many drugs which inhibit aldehyde dehydrogenase, they can cause disulfiram like reaction. That means if after taking the drug person drink alcohol, there may be lot of problems. That is called disulfiram like reaction. Chlorpropamide can do that. So from the name you can remember all these three things. The first three letters will tell. C for cholestatic jaundice, it can cause cholestatic jaundice. H for hyponatremia, dilutional hyponatremia. L means like reaction, disulfiram like reaction. Okay. Then coming to meglitinide group of drugs. The special point about meglitinide group of drugs is these drugs can result in very short duration of action. They work for around 1 hour only. So do you want to control blood sugar for 1 hour only? Obviously not. So what will be their clinical use? They are mainly used in a situation called as postprandial hyperglycemia. Postprandial. Some people, they develop hyperglycemia after meals. Normally the sugar remains normal, but after meals the blood sugar become uncontrolled. So in these patients we can give glinides just before meals, so that when the person take the meal they are at maximum level, and that will produce the decrease in sugar at that time. So they are used to prevent postprandial hyperglycemia. Okay. Now regarding sulfonylurea group of drugs, one very important point to remember, these drugs can cause weight gain. Weight gain. So these are avoided in obese patients. They can result in weight gain. They are avoided in obese patients. Okay. So that is about the oral drugs used in diabetes, that is drugs secreting insulin, insulin secretagogues. Now we will move to second group, drugs acting by other mechanisms. And among the other mechanisms, the most important mechanism will be drugs stimulating the AMP kinase. AMP kinase stimulators. The group of drug is biguanide, and the main drug in this group is metformin. Metformin. Another drug is fenformin. Basically, what happens? AMP kinase, as the name tells, kinase. Kinase means it will phosphorylate. So AMP kinase is involved in phosphorylating many enzymes. Some enzymes after phosphorylation become active, some become inactive. We know phosphorylation is able to control the enzymes, regulate the enzymes. So AMP kinase, when it is stimulated, it will activate some enzymes and inactivate some enzymes. Basically, these enzymes are involved in metabolism. So biguanides, they stimulate the AMP kinase and then they are able to control metabolism. And what we want? Basically, there in the glucose pathway, glucose metabolic pathway, we have 4 processes. One is called as gluconeogenesis, formation of glucose from non-carbohydrates. Second is glycogenolysis, breakdown of glycogen to form glucose. So these are the 2 processes by which glucose is synthesized. So in diabetes mellitus patient, you will want to stimulate this pathway or inhibit this pathway. Obviously inhibit. So whenever AMP kinase is activated, the enzymes involved in these pathways are inhibited. So production of glucose decreases. But on the other hand, the processes which consume glucose like glycolysis and glycogenesis, conversion of glucose to glycogen, breakdown of glucose. Clear? So these processes are stimulated. So that means glucose production decreases and metabolism increases. So that will decrease the blood sugar. These drugs, metformin like drugs, they do not release insulin. So because they do not release insulin, so they will not cause hypoglycemia as a side effect. That is the major advantage. They do not cause hypoglycemia. Okay? Now important point to remember, you can remember they cause 2 important side effects. One is megaloblastic anemia. They cause a deficiency of vitamin B12 that can cause megaloblastic anemia. And second, they can cause lactic acidosis. Lactic acidosis. The question is how lactic acidosis develops. If you see, these stimulate glycolysis. That means anaerobic metabolism. So when anaerobic metabolism is stimulated, the lactic acid production occurs. But normally also in the body anaerobic metabolism occur, lactic acid is produced. But acidosis do not occur. Why do not occur? Because this lactic acid, it is then converted into glucose by gluconeogenesis. But these drugs have inhibited this process. So lactic acid production increases and it cannot be converted to glucose. So the risk of lactic acidosis is there. Clear? And the risk of lactic acidosis will further increase if there is liver failure, kidney failure. In a liver failure, there will be even lesser gluconeogenesis. Little bit which is happening, even that will not happen. So lactic acid is produced, but it cannot be converted to glucose at all. So more risk of lactic acidosis. In renal failure, the lactic acid which has been produced cannot be excreted. So it will accumulate more. Lactic acidosis can occur. And third, any condition which predispose to hypoxia, like COPD. If there is COPD, the person has high risk of anaerobic metabolism, hypoxia, and due to more anaerobic metabolism, more lactic acid production, so more risk of lactic acidosis. So liver disease, kidney disease, lung disease, the risk are higher. Okay. Now among the 2 drugs, metformin more commonly cause megaloblastic anemia. You can remember M4M. Whereas lactic acidosis is more common with fenformin. And out of the 2, megaloblastic anemia and lactic acidosis, which is more dangerous? Obviously lactic acidosis. So because lactic acidosis frequently occur with fenformin, so fenformin is not used nowadays because of side effect of lactic acidosis. Very common. But on the other hand, even metformin can cause lactic acidosis. Although the risk is lesser, but it can cause lactic acidosis. So metformin should be avoided in those situations where risk of lactic acidosis is higher. That means metformin is avoided in liver disease, kidney disease, and conditions predisposing to hypoxia. Okay, so that is one thing. Second, this metformin, it has highest reduction in HbA1c levels. We know to check the control of blood sugar, we use number 1 blood sugar test, which tells the control of sugar for few hours only. Whereas if we want to check the control for 3 months, we do glycosylated hemoglobin. So maximum reduction in glycosylated hemoglobin is done by metformin, or simple language, the most effective drug, efficacious drug. It do not cause hypoglycemia, we already discussed. Hypoglycemia risk is not there. And third very important point is, it do not cause weight gain. Rather, in some people, it can cause weight loss. Remember, weight gain is not there. Many students are confused which whether metformin cause weight loss or it is weight neutral. Remember, in the exam, we are concerned with two things, whether a drug cause weight gain or it does not cause weight gain. So, weight gain or no weight gain. No weight gain will include both. That means no effect on weight and weight loss. Clear? So, metformin in some people do not affect weight, but in some people can cause weight loss. Okay, and this you can remember from the mnemonic most. Metformin, it cause weight loss, so it is used in obese patient. So metformin we use in obese patient, whereas sulfonylureas cause weight gain, so we use in thin patients. Okay? So metformin used in obese, sulfonylurea used in thin patients. You can understand this in Hindi also in simple language. M for metformin, M for मोटे लोगों को देते, S for sulfonylurea, S for सुकड़े लोगों को देते. So metformin in obese, sulfonylurea in thin patients. Okay? So metformin have several advantages: maximum reduction in HbA1c level, no risk of hypoglycemia, and it can cause weight loss also. Okay, so because of all these advantages, metformin is a drug of choice for type 2 diabetes mellitus. So we prefer to start with metformin. It is a drug of choice for type 2 diabetes mellitus. Okay. Apart from diabetes, metformin is also used in polycystic ovarian disease. Again, to control insulin resistance. Insulin resistance is important feature of PCOD. So metformin can be used to control insulin resistance, reverse insulin resistance. Okay. So that is about the first group of new drugs. That means drugs which stimulate AMP kinase, do not cause hypoglycemia, do not release insulin. Now moving to second drug in this group. These are called as glitazones. Their name end with glitazone. Chemically, the name is thiazolidine diones. Thiazolidine diones. No need to remember this complicated name. Remember glitazones, because their name are, the drugs in this group are troglitazone, rosiglitazone, and pioglitazone. Troglitazone, rosiglitazone, and pioglitazone. First of all, how glitazones work. Glitazones, they stimulate a receptor called as PPAR gamma. This is a nuclear receptor. Full form is peroxisome proliferator activated receptor gamma. Now to understand how they reverse insulin resistance is, suppose this is a cell. Insulin receptor is present on this cell. Tyrosine kinase type of receptor it is there. Okay. So when insulin binds to this receptor, it is a tyrosine kinase type of receptor, so it will activate a tyrosine kinase enzyme. So this tyrosine kinase will phosphorylate, suppose number 1 substrate. Substrate number 2 will be phosphorylated by this. Then substrate 3 will be produced. So by many intermediate pathways, finally there will be opening of GLUT channels on various tissues, various cells. So when GLUT channels open, the glucose will come from the blood inside the cells. So blood sugar will decrease. So this is in simplified form how insulin works. So insulin bind to the receptor, that will activate a tyrosine kinase, that will phosphorylate some substrate, that will activate further substrate. So many intermediate substrates are there. So finally there will be opening of GLUT channels. So what happens in insulin resistance? Insulin is able to bind to receptors, but usually some of the substrates are missing. Suppose this substrate 2 is missing. So if substrate 2 is not there, this pathway is not completed. So sugar cannot be reduced. So that is insulin resistance. So what glitazones do? Glitazones, they stimulate PPAR gamma, which is a nuclear receptor. When PPAR gamma is stimulated, the transcription occurs, because it is acting through the nucleus. So it will increase the transcription, or we can say increase the formation of this missing receptor, missing substrate. Suppose this number 2 substrate is produced. So when the substrate is produced, the pathway is completed. So now the resistance is reversed. Clear? So just simple language, remember, these drugs reverse insulin resistance. Clear? Now, do you remember any angiotensin receptor blocker which stimulate PPAR gamma? Tell me the name of PPAR gamma agonist among the ARBs. I'm not asking, I am telling, tell me. So that was telmisartan. So telmisartan also stimulate PPAR gamma and can reverse insulin resistance. Okay. Now, do you remember there is another receptor called PPAR alpha? Which drug stimulate this receptor and for which purpose they are used? Yes, fibrates stimulate this receptor, fibrates. And fibrates are used for hypolipidemic effect, anti-dyslipidemic effects. Okay? Recently, we have developed another drug which can stimulate both PPAR alpha as well as gamma. Both the receptors can be stimulated together, and that group of drugs are named as glitazars. Remember glitazone, the name ended with O-N-E, zone. O-N is 1. They stimulate only one receptor, PPAR gamma. Whereas glitazar stimulate both alpha and gamma, like saroglitazar. Stimulate both alpha and gamma. Okay. Now coming back to these glitazones, troglitazone, it is withdrawn from the market because it can cause liver damage, hepatotoxic. But this is a group side effect. Troglitazone was banned because it is highly hepatotoxic, but other two drugs also require LFT monitoring. They can also cause liver damage. Second problem with glitazones, apart from liver damage, they can cause retention of sodium and water. Glitazones can cause retention of sodium and water. So this retention of sodium and water, it can be harmful in cardiac patients, like patient of CHF. So these are avoided in cardiac patients. And second, retention of sodium and water can cause weight gain. So glitazones can cause weight gain, but it is not fat. It is retention of sodium and water. Clear? So glitazones are avoided in patients of congestive heart failure, like hypertension like patients. Then rosiglitazone, it has been found to increase the risk of myocardial infarction. Although it is still available, but it is prescribed very less frequently nowadays because many cases of MI has been found in patients taking rosiglitazone. And pioglitazone, it is associated with increased risk of urinary bladder carcinoma. Increased risk of urinary bladder carcinoma is associated with pioglitazone. Clear? So these are the important points regarding the glitazone group of drugs also. Question is, will they cause hypoglycemia? The answer is no, because they do not release insulin. They do not cause hypoglycemia. Their name do not end with "ide." Remember, if the name do not end with "ide," they will not cause hypoglycemia. Metformin, fenformin, glitazone, they do not cause hypoglycemia. Name do not end with "ide." If the name end with "ide," they will cause hypoglycemia. Do not end with "ide," do not cause hypoglycemia. Remember, among anti-diabetic drugs. Okay. Then moving to third group of drugs in this category, these are called as alpha glucosidase inhibitors. So first of all, we'll try to understand what is alpha glucosidase. This is our GIT. When we take food, do we always keep on eating sugar, glucose? Obviously not. We take the food in form of complex carbohydrates, or in simple language we can say big carbohydrates. So this is the food which contains big carbohydrates. But we know these big molecules, they cannot cross the membranes. For crossing the membrane, they must be broken down into small carbohydrates like glucose. So we have taken a food which contains complex carbohydrates. It must be broken down into small carbohydrates like glucose for absorption, and this is done by alpha glucosidase. Alpha glucosidase. So if we inhibit this enzyme, if we inhibit alpha glucosidase, what will happen? The big carbohydrate cannot be converted to small carbohydrates. So when they are not converted to small carbohydrates, they cannot be absorbed. And when glucose is not going to blood, blood sugar will decrease. Yeah? So in simple language, these drugs work by decreasing the intestinal absorption of carbohydrates. Okay, the examples are acarbose, miglitol, and boglibose. The first drug, from the name itself you can remember, its name says A-carbo. A means absorption. It inhibits the absorption of carbohydrates. Okay. Now question is, the big carbohydrates, they cannot be converted to small carbohydrates, so they are not absorbed. But the question is, what happened to those big carbohydrates? Those large carbohydrates, they are not absorbed, they are remaining in the GIT. So what will happen? Yes, bacteria की party हो जाएगी. The GIT bacteria, large number of bacteria are there. So now they will start metabolizing these large carbohydrates. But no party is complete without fermentation. So basically, the bacteria will ferment these carbohydrates. And when these big carbohydrates are fermented, what will be produced? Yes, plenty of gases will be produced. So most common side effect of this group of drugs is flatulence. Flatulence is most common side effect of alpha glucosidase inhibitors. Okay. Normally, these gases will not cause any problem. But if the intestine is already inflamed, then production of large quantity of gases can lead to rupture of intestine. So that means these large amount of gases, they can rupture the intestine. We will not take chance. So these drugs, they are contraindicated in patient with inflammatory bowel disease, like ulcerative colitis, Crohn's disease. So acarbose like drugs are contraindicated. Okay. Now the question is, will these drugs cause hypoglycemia? The answer is no again. They do not end with ite. They do not release insulin. They will not cause hypoglycemia. Now a patient is started on glipizide plus acarbose. Can this person develop hypoglycemia? Obviously yes, because the person is taking ite, glipizide, that can release insulin, that can cause hypoglycemia. Normally, when a person is on some anti-diabetic drug and the person develop hypoglycemia, and how do you know person develop hypoglycemia? Yes, by warning symptoms, tachycardia, palpitation, tremors, sweating, all these symptoms will come. So what will you do? What do you advise to the person? So we advise take food. If a person take the food, hypoglycemia will be reversed. Now this person is taking glipizide plus acarbose and this person develop hypoglycemia. And the person immediately remembered कि डॉक्टर साहब ने बोला था खाना खा लेना. So the person takes food. Will the hypoglycemia reverse? The answer is no, because food cannot be absorbed because of acarbose. So what is the solution? So give glucose here, because glucose need not be broken further. Okay? So if hypoglycemia occur while the person is taking alpha glucosidase inhibitors, then the treatment is glucose. Treatment is not food. Okay. So these are the important points regarding the alpha glucosidase inhibitors also. Okay. Now we will move to some new drugs in diabetes mellitus. And first of all, we will talk about incretin mimetic drugs. Incretin mimetic drugs. The first question is, what are incretins? What do you mean by incretin? Incretins are physiological substances. They are normally present in the body. Incretins are the substances which are released when we take food, when we take meals. So when we take meal, these substances are secreted in GIT and their function is to release insulin. So when insulin is released, blood sugar will not increase that much. Okay? So normal physiological mechanism to prevent postprandial hyperglycemia is whenever we take food, some incretins will be secreted and the function of incretin is to release insulin. Okay? And what is the most important endogenous incretin? Yes, it is glucagon-like peptide, or simply called as GLP. Glucagon-like peptide. And the major function of GLP will be to release insulin. Okay. Now, apart from releasing insulin, this GLP, it can also decrease gastric motility. Decrease gastric motility. So when gastric motility is decreased, then the food will remain in the stomach. So when the food already remain in the stomach, the person feels tired. Person feels that I do not need to take more food. So when the person do not take food that much, then it can also lead to weight loss. Okay? And third, these drugs directly go into the brain and stimulate the satiety center. They can also stimulate the satiety center, GLP. In the brain, GLP stimulate the satiety center. And GLP, it has also been found to inhibit the apoptosis of beta cells. Apoptosis of beta cells of pancreas. Okay? So grossly thinking, GLP has two major functions. One, to release insulin, and second, to decrease gastric motility, or we can say help in weight loss. Okay. Now in diabetic patients, GLP is not secreted enough. So if it is not secreted enough, so we need to supplement it from outside. So what is seen is the glucagon-like peptide which is present. After formation, it will be metabolized also. It will be broken also. And the enzyme which breaks this is DPP4. Dipeptidyl peptidase 4. Dipeptidyl peptidase 4. It breaks it down. So what do you want to do to GLP in diabetic patient? Do you want to increase GLP or do you want to decrease GLP? Obviously, we want to increase. So the options we have are, number one, we can give GLP from outside. And number two, we can inhibit the metabolism of GLP. If we inhibit DPP4, GLP will not be metabolic. So these two strategies can be used to treat diabetes. So we'll discuss these one by one, starting with the number one, GLP analogs. So we can give GLP from outside. GLP analogs. The drugs like exenatide, liraglutide, LB-glutide, semaglutide, teduglutide. So the name ending with glutide, name ending with most of them glutide. Yeah. Except teduglutide, all other are GLP-1 analogs, whereas teduglutide is mainly GLP-2 analog. We'll discuss the difference little while later. Now coming to GLP-1 analogs first, we discussed GLP secrete insulin. So these will also secrete insulin, that will decrease the blood sugar. Yeah. So these drugs can be used in diabetes. But from the name you can find their name end with the tide. All of them name end with the tide. Tide means they are peptides. And if they are peptides, means they cannot be given orally. Clear? So all of them are injectable drugs, number one. They are injectable drugs given by subcutaneous route. But special thing, very recently, semaglutide has been formed in such a fashion that it become resistant to GIT enzymes. So it is not broken orally. So semaglutide is the only drug ending with the tide which can be given orally. All other are injectable. Clear? Number two, these are GLP, P for peptide, the name ending with the tide we already discussed. So they release insulin, so they can be used in diabetes. Number two, because they are releasing insulin, they should cause hypoglycemia, but they have very low chance of causing hypoglycemia. Very low chance. The reason being, because they will release insulin only on taking meals. Mainly they are working when the meals is taken. So the risk of hypoglycemia is negligible with these drugs, although can cause, but you need to choose the options very carefully. They have lesser chance as compared to any other tide. So you can remember, any drug ending with the tide among anti-diabetic cause hypoglycemia, but these, they have little bit chance, very less chance of causing hypoglycemia. Okay. Then liraglutide, it is also causing weight loss, so approved in obesity. All of them cause weight loss, in fact. Liraglutide is approved in obesity also. Okay. Now GLP analogs, their major side effect, most common, like majority of the drugs, is nausea. Most common side effect is nausea. But the special side effect to remember, they can cause pancreatitis. Pancreatitis is very important side effect of these drugs. And third very important thing to remember, they increase the risk of medullary carcinoma of thyroid. They increase the risk of medullary carcinoma of thyroid. Okay. Now coming to GLP-1 and GLP-2. We discussed the two major functions of glucagon-like peptide. One is to release insulin and second is to decrease gastric motility. GLP-1, the major function is to release insulin. So all the drugs which are GLP-1 analogs, their major function is in diabetes. Whereas GLP-2 major function is to inhibit gastric motility. Although it can also increase insulin, but the main function is to decrease gastric motility. The major condition where we want to decrease gastric motility is in short bowel syndrome. Basically, suppose there is problem in intestine and we need to do surgery, we need to resect the intestine. So large portion of intestine has been resected. Okay? So what happens now when the person takes food, now very quickly it will reach the large intestine. So the defecation reflex comes very quickly. So that is short bowel syndrome. So if we decrease gastric motility, slowly it will go into the intestine. Clear? So if we stimulate GLP-2, we can produce this section. We can treat short bowel syndrome. So that is done by a drug called teduglutide. So you can remember from the name T for 2. So teduglutide is a glutide which is GLP-2, T for 2. It is used in short bowel syndrome. Okay. So this is the first strategy. We can target GLP. Then second is we can inhibit the metabolism. So if we inhibit DPP-4, then GLP is not broken, level of GLP increase, so we can utilize DPP-4 inhibitors. Their name end with gliptin, like sitagliptin, vildagliptin, allogliptin, saxagliptin, linagliptin. So we have plenty of drugs whose name end with gliptin. These are DPP-4 inhibitors, and the most special point is these are oral drugs. They can be given orally. Remember, their name do not end with tide. They are oral drugs. Like GLP analogs, they have negligible chance of causing hypoglycemia, and it is confirmed from the name here that they do not contain tide in the name. Ide is, they are not ending with ide, so no hypoglycemia. Clear? These are oral drugs. Because they are releasing GLP, they will also cause decrease in appetite. So weight loss can occur with these drugs. So GLP analogs and gliptins can cause weight loss also. Yeah. Now all the gliptins, they are contraindicated in renal failure except linagliptin. Linagliptin is safe in renal failure. Safe in renal failure. From the name you can remember, linagliptin को किडनी फेलियर में भी लेना है, इसको रीनल फेलियर में भी लेना है, इसलिए इसको linagliptin कहते हैं. Okay. Now coming to adverse effects of gliptins. The most common adverse effect of gliptin is nasopharyngitis. Nasopharyngitis is most common side effect of gliptins, and the gliptins can also cause pancreatitis like GLP analogs. Okay, so this is the first new strategy in diabetes, that is to target incretins. Clear? Now moving to second strategy. Second strategy is to inhibit SGLT2. Sodium glucose transporter 2. We'll try to understand first. This is our kidney. The first question is glucose filtered by glomerulus? Yes or no? Yes, glucose is freely filtered. Now when glucose is freely filtered, so how much glucose is present in the urine in a normal person? Almost negligible, nil. So when it has been freely filtered, where does it go? Almost 100% glucose, it is reabsorbed in the proximal tubules, with the help of pump which is called as sodium glucose symport, SGLT2. It help in reabsorption of glucose with sodium in the proximal tubules. The same pump is present in the intestine also. So where it is called SGLT1. In the kidney it is called SGLT2. So it help in reabsorption of glucose in the proximal tubules. Okay. So when we inhibit this SGLT2, what will happen? Glucose will not come back. So that glucose will be excreted in the urine. So these drugs, they act by causing glucose urea. Glucose urea. And when glucose is lost in the urine, it will decrease in the blood. So can be used in diabetes. So these drugs act by causing glucose urea. Now can you predict some side effect based on this mechanism? Obviously when the glucose has come into the urine, the bacteria will also come to eat that. So urogenital infections are very common with SGLT2 inhibitors. Okay. Now coming to the drugs. The name of the drugs end with gliflozin. Gliflozin. The drugs like canagliflozin, dapagliflozin, empagliflozin, ertugliflozin. So the name end with gliflozin, and from the name you can remember everything if you just write urine at the end. So what the name says? Gli means glucose, flows in urine. Okay? Gli flows in urine. So glucose flows in urine. So when glucose flows in the urine, hyperglycemia is treated. But because glucose is present in the urine, it can increase the risk of urogenital infections. Okay. So urogenital infections, there may be urosepsis. Infection can occur. Then a severe type of genital infection called as Fournier's gangrene can occur. Fournier's gangrene is associated with these drugs. Now, these drugs are not indicated in type 1 diabetes. Remember, type 1 diabetes is absolute insulin deficiency. And apart from controlling blood sugar, insulin is also involved in many other metabolisms like ketone body metabolism. Insulin is involved. So this person of type 1 diabetes has absolute insulin deficiency. So we need to give insulin. Now this is a person who is taking insulin. Person is of type 1 diabetes. Then his friend is type 2 diabetic and he was on gliflozin therapy. Type 2 diabetes, gliflozin therapy, it is working. So one day this friend says, who was taking gliflozin, that this gliflozin is excellent drug. It has maintained my blood sugar. So why don't you try this? So this person start taking gliflozin, and when gliflozin is given, it reduces the blood sugar because sugar has been excreted in the urine. So blood sugar become normal, and this person stop taking insulin because the blood sugar is coming normal. A normal person of diabetes, he think that if sugar is coming normal, I am okay. Clear? So the sugar is normal because it is lost in the urine, but insulin is controlling other processes also like metabolism of ketone bodies. When insulin is not present in this person, absolute deficiency is there. So ketone body metabolism is not there. So this person developed ketoacidosis. Sugar is normal, still ketoacidosis is there. So gliflozins, they should not be given in type 1 diabetes because if the person stop taking insulin, there is high risk of developing ketoacidosis, and it is difficult to diagnose also because insulin is this blood sugar is normal. Okay? So these increase the risk of ketoacidosis. Okay. So this is about the second new strategy, that is to target SGLT2. Then we have third group of new drugs which are called amylin analogs. Do you remember amylin is secreted from which cells? Yes, they are secreted from beta cells of pancreas, and they are secreted with insulin. So their function is also like insulin to decrease blood sugar, and they mainly decrease blood sugar by decreasing glucagon. And the drug which we use is pramlintide. Pramlintide. From the name you can find many things. First of all, the name is ending with the tide, means it is a peptide. So it cannot be given orally. So it need to be given by injection, which is subcutaneous. Number 2, its name contains amylin. So if we put a small y, it become amylin. So it is amylin analog. Third thing, its name end with ide. So that means it can cause hypoglycemia. It can cause hypoglycemia. And the last and the most important point which you need to remember, pramlintide is the only drug apart from insulin which is approved in both type 1 as well as type 2 diabetes. Remember, most of the drugs are indicated only in type 2 diabetes, but pramlintide and insulin, they are approved in both type 1 as well as type 2 diabetes mellitus. Okay. Then moving to the last drug in this category, it is bromocriptine. So recently, bromocriptine has been approved in treatment of type 2 diabetes mellitus. It acts by reversing insulin resistance. Now, it has been found that in type 2 diabetic patients in which there is insulin resistance, in many studies it is found that in these patients there is early morning decrease in dopaminergic activity and increase in sympathetic activity. Early morning. Actually, decreased dopaminergic activity is contributing to increased sympathetic activity, and it has been found that the increased sympathetic activity, it resulted in insulin resistance. Actually, this was studies carried out from the migratory birds. The migratory birds, when they are migrating, there is no features of insulin resistance. But when they are hibernating, at that time there is insulin resistance. So when the studies were found out, it was found out that these migratory birds, when they are hibernating, at that time they have low dopaminergic activity, particularly in the early morning, increased sympathetic activity and insulin resistance like features, same features like in human insulin resistance. But when they start the flight, all these changes reverse. So we thought that if we do the similar thing in humans, we can reverse insulin resistance. So we tried that early morning, if we give bromocriptine in low doses, very low dose, the dose required for hyperprolactinemia is very high. So very low dose early morning, if we give dopaminergic therapy, that means bromocriptine, insulin resistance can be reversed. Clear? So bromocriptine has been approved in type 2 diabetes in early morning. This is very important. It should be given very early morning on first awakening. Okay. So these are the important drugs which are used in diabetes mellitus. Thank you.